Thank you all so much for joining us for this important policy discussion. We know that during these crazy times, you all have a lot of things going on, and so we appreciate you making the time, and we will make it brief and straight to the point. Today, I have the pleasure of introducing you to Dr. Brian Blase, Senior Research Fellow with both the Galen Institute and the Foundation for Government Accountability, or FGA, and Sam Adolphsen, our Policy Director here at FGA. Dr. Blase served as a special assistant to President Trump at the National Economic Council from 2017 to 2019. Felt like a lot longer than that, didn't it, Brian? Sam Adolphsen served as Chief Operating Officer for the Maine Department of Health and Human Services under former Governor Paul LePage. As you're very much aware, states are in an increasingly difficult fiscal spot due to COVID-19's impact on their economies and budgets. It's critical that any future relief legislation from Congress is focused, temporary, and doesn't create a cascade of new problems. These two policy experts will share the key findings from their research and 6 recommendations for how Congress can provide both relief and flexibility to the states, as well as what you all should avoid. We hope that you find this briefing useful as you and your bosses evaluate next steps in our nation's recovery. With that, I'll kick it over to you, Brian.
Thanks, Robin. And actually, the 2.5 years that I was in the White House flew by. It was an incredible experience for me. Thanks for everybody joining. 2 weeks ago, the Galen Institute published a piece that I wrote, which I'm largely going to sort of review the main aspects of it with you today. I put together a handful of slides to provide sort of the key takeaways that I want to leave you with. So we can go to the first slide, please. The first key takeaway is that Congress and policymakers have already done a lot. There's been historic action to support states and localities. Congress has already enacted 4 pieces of legislation, along with the Stafford Emergency Declaration. More than $500 billion will be distributed to states and localities. In addition, the Families First Coronavirus Response Act raised the federal Medicaid reimbursement by 6.2 percentage points in every state. And in addition, the Federal Reserve has taken unprecedented action, making loans to states and localities of up to $500 billion. Moreover, states and localities are benefiting from the federal programs aimed at getting money into the pockets of businesses, workers, and the unemployed. Next slide, please. This is a table reproduced from the Galen paper. It shows inflation-adjusted spending by major category over a 3-decade period. 30 years ago, Medicaid was a $100 billion program. Now, it's about a $600 billion program. That's real inflation-adjusted growth of 6 times. 30 years ago, states, and this financing, these figures include federal support for state programs. 30 years ago, states spent 3 times more on education combined than they did on Medicaid. Now they spend as much on Medicaid as they do for education spending altogether. 2/3 of the federal money that states receive is funneled through the Medicaid program. 2 key takeaways. First, state spending has exploded over the past few decades. In real terms, it's up 120%, which is 3.5 times greater than population growth. Second, it's really Medicaid that has driven the state spending increase. Next slide, please. One of the key takeaways from my decade doing health policy research is that the FMAP, which is the Federal Medicaid Medical Assistance Percentage, and that's the percentage that the federal government reimburses state Medicaid spending, that mechanism causes significant amount of waste and misspending. In normal times, and for traditional Medicaid recipients, wealthy states receive about a 50%, they receive a 50% FMAP, and poorer states receive about a 75% FMAP. On average, the state FMAP is 60%. just go through the math here. If a state spends $2.50 total, 60% of that, or $1.50, is reimbursed by the federal government. Another way of thinking about that is when a state spends $1 of its own money, it gets $1.50 of federal spending. In the legislation that the House Democrats passed last week, they would increase the federal Medicaid reimbursement by 14 percentage points. It would take it to about a 75% FMAP. The math there is that $1 of state spending is able to leverage $3 of federal spending. The final column shows the reimbursement for the Obamacare Medicaid expansion population. That's a 90% reimbursement rate. The states that spend $1 on the Obamacare expansion population get $9 of federal spending. Now, one of the issues is that states get more federal money when they spend more, but also if they create fake expenditures. And states have gotten very creative at developing accounting gimmicks that give the appearance of actual expenditures. Many of these gimmicks involve overpaying providers, obtaining the federal reimbursement on the overpayment, and then requiring providers to return money to the state. It's widely acknowledged that these gimmicks are scams. One very notable person, former Vice President Joe Biden, actually referred to one of these types of scams, so-called provider taxes, as a scam and urged reform. Often, states take this money and don't use it for health care or long-term care expenses for low-income populations. Instead, they divert it for other purposes like schools or roads. Now, again, the Obamacare contained really bad incentives. It's now a 90% FMAP. It was higher in the first couple years of the program. And as a result of the bad incentives from the ACA, we know that Medicaid's improper payment rates have exploded. They almost certainly exceed $75 billion annually now, or 20% of all program expenditures. Before the ACA, the Medicaid improper payment rate was about 6%. Much of the improper payment rate has been driven by states being lax on eligibility and signing up lots of people for Medicaid who either aren't eligible or enrolling them under the terms of the Obamacare expansion when they're really eligible under traditional Medicaid. Importantly, a lot of this spending doesn't produce high value for recipients. In 2015, economists at Harvard, Dartmouth, and MIT did a pretty comprehensive analysis and found that Medicaid recipients only receive about 20 to 40 cents of benefit for every dollar of program spending. In addition to increasing wasteful spending, and we can go to the next slide, raising the FMAP produces major inequities between states. Raising the FMAP tends to benefit wealthy states who have greater fiscal capacity and who have grown larger Medicaid programs. So this table it shows some select states, the full table's in the Galen paper, and it shows federal spending per person in poverty. And you can see there's major inequities. New York, one of our wealthiest states, receives almost $15,000 in federal spending per person in poverty, which is 3 times more than states like Texas, Florida, and Alabama receive. Yesterday's lead editorial in the Wall Street Journal actually asked the question of whether Florida should bail out New York. The Journal argued that the answer should definitely be no. In part because of sort of how profligate New York's Medicaid program has become, and that federal taxpayers and those in Florida shouldn't be bailing out New York for growing a very expansive and unaffordable Medicaid program. The main takeaway is that when Congress raises the FMAP across the board, and it tends to do these when we face crises, is that it favors wealthy states with bigger Medicaid programs that just so happen to be pretty deep blue states. Next slide. So that was a discussion of sort of the main problem that we face. What should Congress do? The first thing Congress should do is take their time. There's already been so much that has happened that they have passed, that the Fed is doing. Take time, understand the ramifications, and then reject bad proposals. So at the end of March, the House Democrats introduced legislation that tied the FMAP to the state unemployment rate. This legislation would have permanently increased the FMAP and counterproductively sent more aid to states with higher unemployment rates. I analyzed this proposal in both the Galen research and in a Wall Street Journal op-ed on May 4th. Fortunately, and I can say one good thing about the HEROES Act that the House Democrats passed on Friday, it didn't contain this proposal. If the proposal comes back, I'm glad that I did the analysis. What the HEROES Act did, which I mentioned, is it increases the FMAP by 14 percentage points from July 1, 2020 for a year, and then after that year period, it reverts back to the 6.2% FMAP percentage point increase that's in the Families First coronavirus response. Outside of the FMAP increase, one of the reasons that the legislation is deeply irresponsible is that it increases state and local aid by roughly $1 trillion, an amount so large that one key analyst doesn't think that states or localities will be able to spend that much money that quickly. If Congress ultimately decides that more aid is needed, action should be guided by 4 principles. First, the aid should be temporary and capped. The aid should be focused on the problem at hand and not make states even more dependent on the federal government. Second, don't increase the FMAP, as we've gone over. It creates bad incentives for wasteful spending, and it disproportionately benefits wealthy states that have grown larger Medicaid programs. State dependency on Medicaid will deepen if the federal government picks up more of the costs now and in the future. This will lead state governments, even conservative ones, increase reliance on Medicaid to fill budget holes, and it will reduce fiscal discipline in state capitals. Third, aid shouldn't discourage economic reopenings and work. Casey Mulligan, who served as chief economist at the White House Council of Economic Advisors in 2018 and 2019, wrote a book on the weak economic recovery after the 2008 financial crisis and really attributed most of it to the problem with government programs that discouraged work. While it's understandable that Congress wanted to help the unemployed, the $600 a week unemployment benefit is a massive problem that is making it extremely difficult for businesses to rehire workers. It will significantly delay the recovery. Congress should be looking for ways to restart the nation's economic engine. If Congress looks to send money to states, it should use things like the state population or retrospective figures like the state poverty rate or uninsured rate. Finally, you need to insist on structural reforms that improve the federal-state fiscal partnership. First, consider gradually equalizing the reimbursement rates across populations. Obamacare's enhanced match rate for the able-bodied working-age adults provides states an incentive to spend less on more vulnerable Medicaid enrollees, to classify enrollees as eligible under the expansion, and to spend more carelessly on the expansion enrollees. Congress could, over a period of several years, lower the enhanced match rate until it equals the match rate for the traditional recipients of the program. Second, Congress could codify the Medicaid fiscal accountability rule. In November 2019, the Center for Medicare and Medicaid Services proposed this rule to shed light on Medicaid's hidden financial arrangements. The rule really is about understanding where Medicaid spending is going and limiting the types of financial gimmicks that states can employ. Its importance is increased given the surge of Medicaid spending that will occur from both the recession and the higher FMAP. And if you're interested in good nighttime reading, I penned about a 5,000-word health affairs piece that summarizes the Medicaid fiscal accountability rule. Although it's technical, I believe this rule is incredibly important and would improve the federal-state Medicaid partnership. Third, Congress could require CMS to conduct annual eligibility audits of state Medicaid enrollment. Actually, the Obama administration canceled CMS audits of Medicaid eligibility from 2014 to 2017. Now, the HHS Inspector General did their own audits, and CMS restarted audits in 2018. And all of the audits have found significant problems because states have responded to the incentives in place and are going after the enhanced match rate. Congress could require CMS to conduct audits of every state each year and ensure that the audits are meaningful and that the federal, which would require the federal government being able to recoup money from states after they do an audit. With that, I'm going to turn it over to Sam, who's going to talk through our 3 other recommendations.
Great. Thank you, Brian. Appreciate it. I can verify what you said about the health affairs piece. I keep one on my bedside table for those sleepless nights. No, it's great to have Brian on the call. He was a terrific partner for us when he was in the White House, and it turns out he's just as good a partner back here on the private side of things. So appreciate that. I want to pick up right where you left off and tell everyone about 3 more problems, major issues here with Medicaid, and then the 3 reforms that could be implemented to fix those problems. And I wish I could give you good news, but these are all bad. They do have solutions, so I guess that's the good news for the day. I'm going to start here from the bottom of this list and work my way back up. The reason, because I want to spend the most time on the final one and leave you with that. So let me start first with eliminating hospital presumptive eligibility. So hospital presumptive eligibility, this kind of innocuous sounding policy, was actually passed in Obamacare, the ACA. And what it does is it expanded the ability for hospitals to actually presume someone's eligible for Medicaid and then deliver services and charge Medicaid for those costs. And the hospitals can do this by simply taking an income statement and the person's name, and based on that reported income, they can deem them eligible. Now, there are a number of problems with that, as you can imagine. One of the chief problems being that if they're wrong, there is no way for the state or the federal government to recoup that money. So if they deem someone eligible who turns out not to be, all the money that was spent in that interim period is gone. The hospitals keep it. There's no way for the state to claw that back. This is something that is a state option, but naturally many states have taken it and used it to essentially to give hospitals the keys to Medicaid eligibility. Huge problem in California and New York. I'll give you a little preview of a paper that's coming out in the next couple of weeks from FGA. We FOIA'd a bunch of states, got this data, and about 70% of the cases that are deemed eligible through hospital presumptive eligibility turn out to be ineligible once they actually complete a full verification. So that's something we like to see if Congress goes back into Medicaid and does something here, like Brian was talking about, we'd like to see hospital presumptive eligibility eliminated. The second issue is eligibility reviews. So before Obamacare, the ACA, states had the option to do eligibility reviews of Medicaid recipients more than once a year. States often did them on a 6-month interval, and they had kind of an option to tailor that the way they wanted to as a state. Well, there was guidance, kind of sub-regulatory guidance issued during the Obama years that actually bans states from conducting those checks more than once a year. So right now, once someone's on a Medicaid program, they are not reviewed until 12 months later. And we know that many of these folks during that interim period between when they come on and when they're reviewed have changes in their circumstances that the state is not catching. So the state of Florida said when people come up for eligibility reviews, about 30% of them are no longer eligible. This is a huge area of fraud. There's about $75 billion a year in improper payments, and more than 60% of those are related to eligibility errors. So we're talking tens of billions of dollars that could be directly combated by simply allowing states to do checks more frequently. So that's the second one. Brings me to the third reform that I'm going to cover, and I think the worst of them all, and it happens to be the most recent as well. So the Families First Corona Response Act, this was the first kind of wave of congressional action around the coronavirus. It included the FMAP bump that Brian mentioned, about 6% FMAP bump to the states to get them some additional funding. However, it also included something that Democrats and the left refer to very affectionately as maintenance of effort, or MOE, where they're requiring states not to implement any new eligibility standards. And it goes even further than that and says that states who have program integrity measures on the books in state law, things like more frequent checks or checking additional data sets, doing household verification, states must ignore those laws in order to receive the funding. They have to default to the federal minimum requirements on all these things in Medicaid. And then probably the worst piece of this provision in the FFCRA is that states cannot remove anyone from Medicaid for any reason after they come on the program, going back to March 18th of this year, all the way through the end of the public emergency declaration. So you can imagine a scenario where people are coming onto Medicaid in droves. Their situation may be changing as they go back to work, as they have more income. States are not allowed to remove them from the program. They're not allowed to remove them if they're earning $100,000, if they committed fraud to get on the program in the first place. Once they're in the door, they must remain on the program through the end of this public health emergency. There's initially some folks thought, well, no big deal, right? It's temporary, it's tied to the end of the emergency. But we know that the CBO is projecting at least through March of next year that the emergency will remain in effect. And we know from the kind of the last H1N1 swine flu issue that went for 15 months that emergency order was in place. So we're talking about, at a minimum, for a year, states will not be able to remove anyone from Medicaid. And this comes at a time when obviously their budgets are in complete disarray, their revenue, the tax income has collapsed. We all know what's happening there at the state budget level. And Medicaid is one of the top, if not the top, budget line item in every state. And so Congress has effectively handcuffed them with this money. They've taken away their ability to manage the Medicaid program in exchange for what amounts to really not a huge amount of money compared to what they'll spend on increased eligibility. So those three things: eliminating hospital presumptive eligibility, permitting more frequent reviews, more than once a year, and then this really major one that needs to be addressed right away of giving states the ability to move people off Medicaid when they're ineligible and really make sure their programs are in good order during this time, are three major reforms, structural reforms that can be done to help stop the Medicaid explosive growth that we're seeing. Thank you. I will turn it over now to Grace Marie.
Thank you very much, Sam, and thank you, Brian. Thank you, Robin and Andrew, for facilitating this conversation. I just want to leave you with a couple of quick thoughts. We do want to keep this to 30 minutes, and that is that whatever responses that Congress makes to help states and localities needs to be temporary, limited, and focused. And a vast expansion of Medicaid, a tremendously problem-prone program, will not do that. The information that we have for you from this presentation, if you would like a copy of the PowerPoint, send a note to Robin at thefga.org or just respond to the email invitation that you received. But the crucial thing is to not use Medicaid as a platform.